What made you choose this branch?
Surgery chooses you. You cannot choose surgery.
That surgery is a very toxic branch. You have gone through the toxicity.
See, it's not a toxic branch.
6 days of hard labor, 7th day long classes. Weren't you physically and mentally exhausted?
It is exhausting. And I think it's the same even today.
So do you think that's okay?
So if you've chosen a surgical branch, that is how it is going to be. There's no other way.
Tell me about the time you finally gave the exam. How was the whole procedure?
Or I could not see any significant reason why these people cleared and these could not clear.
कि MS में एग्जामिनर बैठता है आपको पास करने के लिए और DNB में एग्जामिनर बैठता है आपको फेल करने के लिए. Income to effort ratio is really bad.
Income to effort ratio in all surgical branch is bad initially.
Is it all worth it? Being the surgeon?
If you would have asked me in 2013, I would have said no. If you ask me today, I would say yes, it's worth it.
Tell me, what is the ugliest truth about becoming a surgeon that nobody knows about?
The first decade after your MBBS, your everything will be tested.
So what's the realistic income expectation? What a general surgeon can achieve, like immediately after doing his MS or DNB, 10 years down the line, 20 years down the line. Hey guys, welcome to the Nachiket Bhatia Show. Today's guest is Dr. Pushkar Anand, a senior consultant in General and Laparoscopic Surgery with over 16 years of clinical experience across Delhi NCR. He completed his MBBS from DY Patil University and DNB in General Surgery and is known for his work in minimally invasive, laparoscopic and emergency surgical care. Today we are going to discuss about surgery in detail, the difference between MS and DNB, the hardships a resident goes through when he is doing DNB, the procedure a DNB exam carries, and whether it's a good choice to become a general surgeon in today's era. Is MCH or DNB a compulsion? Let's find out. Let's put our hands together and let's welcome Dr. Pushkar Anand. Welcome, Dr. Pushkar, to the Nachiket Bhatia Show.
Thank you. Thank you for having me on the show.
Boss, you have a great profile, a great bio, and we are going to talk about surgery in detail with you. But before that, I would like to know your own personal journey. कैसे आपने शुरुआत करी? How did you get into the field of medicine?
So getting into the field of medicine was a mix of a lot of things. Little personal ambition, little bit of parental expectation, and kind of calling to serve, and I think a mix of a lot of things. And also my inclination towards physics, chemistry, and biology, and that's a very basic prerequisite. So I think a mix of everything.
So you chose to do medicine. Was it just a practical decision or were you really inclined to this field?
So I was okay with it. There was a kind of parental expectation. And then there's also a kind of perceived notion that, you know, it's a very safe branch and it's a safe thing to do. It's a very respectable thing. So I think I would say that everything coincides and, you know, I landed up in medicine.
What about surgery? What made you choose this branch?
So you can choose MBBS, but surgery chooses you. I mean, you cannot choose surgery. Surgery is basically a calling, and most of the students that you'll come across, they almost make up their mind in the final year or the pre-final year or during internship that they have to become a surgeon. So I would say that I was very inclined towards it right from the very beginning.
You did DNB from Jaipur Golden.
Yes.
So I'll ask you a little bit of a different question. You have done your MBBS from a private college.
Yes.
Even then, I think there must be a lot of pressure around you. You know, there's a whole conception around this that private college students have a real difficult time to get into a PG course.
Absolutely.
How did you get past that pressure mindset?
I went into a private medical college also through an entrance exam. So it wasn't that I had paid some money or, you know, got into the private medical college through a management quota seat. So I was very sure about it. Like, I did not have an iota of doubt that since I've come here, I might not make it further. And as far as surgery is concerned, I was very inclined towards it. I wanted to do surgery because I had done my internship and my junior residency from Delhi, from Hindura Hospital. So I had it in mind that, you know, if I could get a seat in Delhi in general surgery. And that is how this, through DNB entrance, I got a seat in Jaipur Golden. I was lucky enough because back then, the seats used to be very less. There were around 15, 20 seats of general surgery in the whole of Delhi. So I was lucky enough to uh, get the seat. And I think ours was the first time that DNB had conducted an entrance exam way back in 2010. Before that, it was based on interviews and some marks, and they had some other parameters, but it wasn't on the basis of entrance. Only in 2010 they started the entrance exam, and I was lucky enough to get a seat.
Were you scared not choosing MS and going for DNB?
No, I wasn't. Primarily because I had worked in Hindu Rao Hospital for good 1.5 years, and I had seen a lot of DNB, a lot of students, writing DNB exams and clearing it. So I knew that it's difficult to clear a DNB exit exam, but I wasn't doubtful about it. I mean, I did not have that kind of uncertainty or that doubt that I might not clear it.
Tell me about your residency days.
Residency days.
Let's start with the year one. That's the most difficult one, right?
So year one, Jaipur Golden Hospital, it had around 200 to 50 beds. We were 6 residents, and we used to have a lot of, and there were multiple consultants. I think around 10, 50, around 5, 10 consultants in general surgery. So there was a reasonable amount of work, and we used to have a lot of patients coming from Sonipat and Panipat, landing up in Jaipur Golden. So we also had a lot of trauma exposure, gunshot patients, primarily coming from Panipat and Sonipat, because that highway was very easily accessible to our hospital. So the exposure was good, and the only thing I realized that during residency, you just have to be available. Come what may, you have to be available for your surgeon, for your consultant, and only if you're available, things will fall in place. Second thing, we were very fortunate. We were God blessed. We were very lucky to have one of the best teachers of India teaching us back then. Dr. G.D. Sharma, I think he's undoubtedly one of the best teachers of this era, one of the best surgical faculty of this era. So we were very fortunate enough to have him, we all were taught by him. So I think that helped a lot. We used to have long marathon classes on Sundays, starting from 11 or 12, 11 a.m. or 11:30 a.m., going up till 6:30, 7:30. So we never had an off day. 6 days used to be a work, and on the 7th day, that is Sunday, we used to have this long marathon class, and so I used to come and grill all of us. So learning was good. There was no time for anything, but overall it was a good learning experience.
So basically, the point that surgery is a very toxic branch, you have gone through the toxicity.
See, it's not a toxic branch. Like I told you, surgery is a calling. You don't choose surgery, surgery chooses you. So once you have made up your mind that you are going to pursue your career as a surgeon, you have to be mentally prepared for it. There's nothing that will prepare you for all this. You join as a first year DNB or a first year MS resident, and 2 a.m. in the morning, you have a 20-year-old boy with a skull open, or a gunshot patient arriving from Panipat or Sonipat. No one prepares you for this. Now, and you have to be available, because that is the only way to get the cutting opportunities because any emergency, any pain, nothing will have a schedule or a calendar. So you just have to be available all the time. Now, if you are available, it's up to you whether you call it toxicity, or whether you call it utility, or whether you call it your optimum utilization. Because I think any surgical branch merits a lot of availability in the OT, a lot of availability in the ER, a lot of availability in the wards during the learning period. So I would not call it toxicity. And thankfully, we had wonderful seniors, we had wonderful consultants, all were very happy, and we had a wonderful teacher. So I would not call it toxicity.
6 days of hard labor, 7th day, long classes. Weren't you physically and mentally exhausted?
Yes, it is exhausting, but that is how you expect it to be trained. It is exhausting, and I think it's the same even today.
So do you think that's okay?
See, if you're choosing a surgical branch, it's not your choice. It's not up to you whether it's okay or it's not okay. That's the way it is, and that's the way it will continue to be. And if you have to, if you enter a post graduation and if you want to see yourself settled after another 5 years, so it's purely up to you whether you want to concentrate your learning within those 3 to 5 years, or post MBBS first 8 years, or whether you want to keep learning all your life and talk about work life balance and toxicity. So if you've chosen a surgical branch, that is how it is going to be. There's no other way.
I have a complaint. 90% of you have still not subscribed to the channel. So before moving forward, please go ahead, press the subscribe button and click the bell icon. So honestly, if I ask you this, would you consider surgery a branch where there is even a little amount of work-life balance?
So Nachiket, initially there won't be any work-life balance, to be honest. Later, yes, you'll have. Once you have done with your PG, maybe another 5 years, if you plan to do MCH, so another 3 years of MCH and maybe 1 or 2 more years of refining your skills. Or if you've done your post graduation, maybe another 5 years to refine your skills. So post MBBS first 8 years, if you are into a surgical branch, it is not okay to talk about work-life balance. Post that, after that, yes, you have work-life balance. You have, because then you have a team, you have people to take care of things. You are reasonably experienced. You are not into that rat race of acquiring skills. So I would say that later, after 35, 36 years of age, you have work-life balance, but initially you would not have work-life balance.
So what was your typical day like during your JR1 in the residency?
So we had to, so our unit head was Dr. Subodh Gupta. He used to take our classes in the morning from 7:30 or 8 a.m. So we used to have 1 hour of class in the morning, followed by our usual OPD and ward rounds, and making discharges and attending the emergency calls, if any. Sometimes you were asked to come to the OT. So every resident was attached to one of the units, or जिसका भी OT day है, that resident used to follow his consultant, और जिसका OT day नहीं है, he's taking care of the wards, he's taking care of the emergency, he's taking care of the OPDs. So this used to go until 5, 6 p.m. because evening rounds used to be at around 5 p.m., 6 p.m. So this goes on until 5, 6 p.m. And then you have to study after that. And if you're on call, then you have to stay back in the hospital. If you're not on call, then you have to come back home and obviously study, because in DNBs, there's also this very, that uncertainty is there that you might not clear it. So wo shuru se rehta hai, from day one, it is playing in your mind that, you have to study hard so that you get through the exam.
Tell me about the time you finally gave the exam. How was the whole procedure?
So I wrote my exam in 2013. I cleared the theory part of the DNB in the first attempt itself. For the first attempt of my practical, my exam was in Kolkata. I think it was NRS Medical College, Kolkata. And 27 people appeared, and I think 3 or 4 students cleared. I did not clear. So that kind of put me in self-doubt, and I could not figure out any reason, or I could not see any significant reason why these people cleared and these could not clear, because I think 3 or 4 students had cleared and rest 23, 24 could not clear. So we really did not know. We were a bit clueless. So those moments kind of put you in self-doubt, and those are really testing times. You start doubting the entire, process. Then I appeared for my second attempt of practical exam in, and during my first attempt of practical exam, I had a son who was less than 1 year old, and once the exam was over, all 27 of us, we knew that we are not going to clear. All of us had the same notion, though 3, 4 of them cleared, but all of us knew that we are not going to clear.
Was it extremely hard?
It was difficult. It was difficult. Because externals come from all over the India. The place is new. The patients, so half the patients did not know Hindi. They could only speak Bengali. We did not know Bengali. So there were challenges, and so by the time the exam was over, we knew that I knew that I'm not going to clear, and I think that was the general vibe across all of us, that none of us are going to clear.
So you felt that thing जो
So I
कहते हैं
felt
ना
bad. I felt bad. I have a 1-year-old son.
कि एमएस में एग्जामिनर बैठता है आपको पास करने के लिए और डीएनबी में एग्जामिनर बैठता है आपको फेल करने के लिए.
See, it's a very harsh way of going about it, but MS में एक छोटा सा फायदा ये होता है कि आपका वो होम सेंटर है. You have people around you जो और जो patients हैं they at least speak your language. DNB में back then it was not the case. My second practical exam was in Ahmedabad where the patients knew Gujarati but they like could speak Hindi. So ये एक थोड़ा सा फायदा है, but I don't think that anyone is biased to किसी को फेल करना है या किसी को पास करना है. But obviously ये वाला एक bias play करता है because suppose you have been working with me for the past 3 years, है ना, and I know that you're sincere and I know that you have been putting a lot of hard work, and then I come and take your exam, I will obviously have little bias that नचिकेत से गलती हो गई but ठीक है, मतलब
लड़का ठीक है पास कर दो.
लड़का ठीक है. तो ये वाला एक bias play थोड़ा सा करता है which is absolutely not there in the DNB practical exams. No one knows you. Neither the staff, nor the nursing staff, nor the patient, nor the gate man, nor the surgeon. No one knows you. So you're absolutely clueless. So that does play a role. It's same like India playing a test match at Kolkata or Wankhede, and India playing in Durban or Gaba.
उसके बाद what was your career chart?
Then after my final year, once I cleared my DNB, I went back to Patna, my hometown. And I worked there for around 5 years, from 2013 to 2017. So I had joined a charitable hospital where I had lots of hands-on. And I had joined multiple small clinics and nursing homes where I could go and do the surgeries. And I had also started visiting the nearby villages where there were no doctors. And I did this for good 9 years. And so I was going to a place called Parihar in Bihar, and that is the last village from Indian side. And after that, there's this Indo-Nepal border, and after the border is that Janakpur, the birthplace of Sita Mata. This side is called Sitamarhi. So I was going there, and I was attached to multiple other hospitals. And that is how it was. So most of my learning happened there. Most of my cutting chances and most of my learning happened there. That was a very unconventional way of going about things. But I think destiny had that plan for me.
You did not think of doing MCH?
Nachiket, I had, to be very honest, I never felt work deprived during my initial years. And there were certain things going on at my home and my family, which required me to stay there, right? There were some certain things so it required me to stay there. So I had no option of leaving Patna for any reason, A. And B, this whole thing, because many people think that if you are only doing general surgery, you'll be work deprived. That is the notion, this notion has been going on for the past 20 years, that, general surgery is a dying branch and, you won't get enough work, but I don't think that's the case. So I had enough work back then. So that idea, and also because of my certain personal involvement in certain things back home, I did not have this opportunity or this option to write an exam and go and pursue a MCH 3 years, go and pursue MCH for 3 years and leave my home or my family. So I had to stay back. So that is one reason I did not pursue MCH.
I think I'll ask you this question, a very direct question. Do you think general surgeons are losing ground financially to super specialists? Because every now and then I see even, the local public in especially tier 1 cities, they are asking for super specialists more than general surgeons.
See, Nachiket, I've been in private practice for almost 12, 13 years now. Now, this question very often it comes up. I'll give you a very simplified and a very realistic picture of the entire thing. So you're losing ground. When you say you're losing ground, you mean to say that patients are not coming to you, right?
True.
And when you say patients are not coming to you, that means you're not earning well for yourself, right? That is how it works. Now, you need to understand that any specialty, whether that is surgery, orthopedics, GI surgery, they are very basic three things that brings a patient or convinces a patient whether he wants to get operated by you or not, right? So one thing you are very clear that there are certain surgeries that are being done by general surgeons. There are certain things that are being done by gynecologists. There are certain things, and that will be there as long as the population of the country survives. Those things will be there. Now the question is that those people who merit those surgeries, will they come to you or will they go to the super specialist, right? So this question has been going on for the past 20 years. I mean, when I joined MBBS, even then people back then used to say that, general surgery is a dying branch and CTVS is a dying branch and, pediatric surgery is a dying branch. So now there are three things. The first thing is that the moment a patient enters your clinic, he or she can spot two things within the first 30 and 60 seconds, within first 30 to 60 seconds. One is conviction and second is compassion. And if he or she spots conviction and compassion on your face, that translates into trust. And compounding of that trust over a prolonged period of time, that leads to your fixed clientele, that leads to money, that leads to more number of surgeries. So there's a process, whether you do general surgery, whether you do MCH GI surgery, whether you do GI onco surgery, whether you do gynecology, whether you do orthopedics. Every specialty will have to face this triangle. Now, how does a patient spot conviction, or how does a patient spots compassion? So conviction primarily because you have spent so many numbers, you have devoted so much of your time in the OT, you have given you everything in the OT, you have been in that situation, bailed out that patient so many number of times, you are pretty sure about the outcome. That brings conviction on your face. And the compassion part is like when you are very ethical, when you know when to get into a surgery, when not to get into a surgery, when you understand the magnitude of the patient's problem, and when you give affordable and viable solutions to the patient. Patient can sense that. Now, as long as conviction and compassion stay in your practice, patients will keep coming to you. No branch will die. But if you are trying to chase money, if every right iliac fossa pain you label him as appendicitis, if a grade one, if you tell a grade one pile patient that you merit surgery, every patient who's capable of, I'm talking about gynecologist, every patient who's capable of delivering, undergoing a normal delivery, you suggest him that he or she should undergo LSCS. If you little bit dilute your ethics, over a period of time, patient will sense it. So I would suggest that no branch is going to die, no super specialty will ever take up general surgery or general medicine. You just have to have conviction, compassion, and patients will keep coming. Any specialty, the trickling will begin someday. Now, how much you can sustain that trickling, how much you can maximize on that trickling, that is a time-consuming thing. And I think I know GI surgeons who are doing gallbladders day in, day out. I know a plastic surgeon who's doing 10 LSCS in a day, 8 LSCS in a day. I'm talking about a plastic surgeon in a tier 2 city. His bread and butter is this thing. People are coming to him.
But that's again an MCH branch, right?
That's again an MCH branch. So if you associate, like the general perception is that certain degree amounts to certain amount of money, which is a myth. It's not that. It is competence which translates into money. It is not the degree. It is not it is the number of hours. It's the competence that eventually translates into money.
So this is the point that I'm trying to make.
And if you're willing to make your way out, things do fall in place. And like I would never relate any specialty or any particular super specialty to any amount of money, which is a very notion, especially in young surgeons, that if you do GI onco, you'll get certain amount of money. If you do certain branch, you'll get certain amount of money. I don't think so. I have seen big teams where the junior most guy, he slogs for 5 years, 7 years, and he still has 3-4 guys on top of him. And he's a GI guy, he's a MCH guy. So I think it is there. It's basically how you chart your way. It's more about that, whether you want to go independent, whether you want to work in a team, whether you kind of you're okay with that kind of money, or you're okay with investing that kind of time for that particular specialty. It's all about.
What would be your advice Looking at the current scenario in today's world, to a new general surgery passed out, should they go for MCH compulsorily, or should they? I mean, they can have a career through general surgery.
See, in tier 2 and tier 3 cities, there's no need to do a MCH. I mean, you can jolly well do with a simple DNB or a MS degree. In tier 1 cities, there are quite a few corporate hospitals, and the number of doctors are also like uh, we are overpopulated. We are oversaturated with doctors in tier 1 places like Delhi NCR. So obviously, making your place is not as easy as it will be in a tier 2, tier 3 city. So in a tier 1 city like Delhi NCR, by default it becomes a prerequisite to get a MCH seat, so that you get a decent salary. So if you look at it that way, but then excelling from there, it has got nothing much, like once you've got a certain job after MCH, or if you've got a certain job after general surgery, excelling from there, the degree doesn't play a role.
That's true. But doing MCH now, is that a compulsion or not?
It's not a compulsion, but most of the people are pursuing it. It's not a compulsion.
Was talking about money. Why do people think that surgeons become rich from day one?
See, it's primarily because whenever anyone is in surgical need, he goes to a established surgeon, right? Someone who has spent his 10 years post PG or post MCH. So once you go to a established surgeon and you interact with him for a reasonably long period of time, you conclude that everything is sorted at his end. They don't see the sleepless nights. They don't see the very low stipend that he had initially. They don't realize the initial grind that he went through. So that is a perception problem, because when you're meeting someone who's at the peak of his career, and then you have the same expectation from a young professional. So there's a learning curve, there's a growth curve, and that has its own gestation period. So it takes a little time, but yes, people perceive that surgeons have money from day one, but that's not the case.
So, what's the realistic income expectation? What a general surgeon can achieve, like immediately after doing his MS or DNB, 10 years down the line, 20 years down the line?
See, depends on where you're practicing. If you're into private practice or in a corporate job, or on some government setup, and whether you are willing to do a job as well as do a little bit of freelancing. So I think after post graduation, I think it is anything between 1.5 to 2.5 lakhs, depending upon the standard salary that you get. You may earn 30, 40, 50,000 extra by freelancing, a couple of INDs, a couple of appendix, a couple of gallbladders you may get in a month, because even the small nursing home, they want the senior surgeons to come and operate. So that way it is little compromise for young surgeons. But I think a real expectation should be anything between 1.5 to 2.5 lakhs. 2.5 lakhs on the higher side.
10 years down the line and 20 years down the line.
10 years down the line, there's no limit. 20 years down the line is also very unpredictable. It lot depends upon how much of initial grind you have gone through, or how much dedicated hours you have put into the practice, and how much you have understood the practice. So I would say if you're in a regular job, starting from 2.5 per month, you increase it by 10% every year, right? So suppose it is 30 lakhs a year, 25 to 30 lakhs a year, or 20 to 30 lakhs a year. So you increase it by 10% if you're in a regular job. But after a certain point of time, you start getting more opportunities from local nursing homes and hospitals. So I would say that you can add around a lakh or so with the job, primarily because you're in a job 9 to 5. And if you have your own clinic, if you're on revenue sharing, so the amount may increase. But it all depends that, how many patients you are catering, how many opportunities you're getting from the nearby nursing homes, what is the kind of trust and faith your colleagues have in you, the kind of referrals that you're getting. So depends on a lot of things. But I would say immediately after PG, it should be anything between 1.5 to 2.5. After 5 years, a reasonable expectation should be anything between 3 to 5 lakhs, 2.5 to 5 lakhs.
There's so many surgeons who are stuck in the range of 2 to 3 lakh rupees a month, even after decades of practice.
Yes.
Why is that?
It's all about the choices that you make. So um, primarily because if you take up a job 10 to 5 or 9 to 5, I'm talking about those surgeons who are in a fixed job in a government setup or in a private setup. But if you kind of and if you're not very aggressive about increasing your practice, if you want work-life balance after 5 p.m., you don't want to attend your clinic. If after 5 p.m. you want to go back home, sit and relax, which is absolutely okay. Which is, I mean, some people have make those choices. So there, obviously, your earning is directly proportional to the number of hours you are spending in the OT or the number of hours you are spending in acquiring the patients. So if you make it 9 to 5 thing or 10 to 5 thing, obviously the earnings will be limited. But if you stretch yourself a little, if you are willing to do the evening OPDs also, if you're willing to operate even on uh, second half of Saturdays and first halves of Sundays, and if you're willing to kind of do a little bit of freelancing, so I think that's not the case. But if you're not willing to do all that, then yes, obviously there'll be financial constraints.
So do you think that the income to effort ratio in general surgery, especially, is really bad?
Nachiket, income to effort ratio in all surgical branch is bad initially for first 5 to 8 years. You will never be able to match the financial outcome with the kind of effort you have put in, no matter what branch you are in. I'm talking about the surgical branches. But later on, it's rewarding. After 5 years of post graduation or after 3 to 5 years of MCH, it's genuinely rewarding. But if you ask me initially, it is not rewarding. It is, there's a slight imbalance.
So if a medico for whom money is a top priority, is general surgery the right branch?
Initially, no, because money comes late. Money will come after probably 5 or 6 years of post graduation. Money will not come easy. Maybe after 10 years of post graduation, so money won't come easy initially. So if you are chasing money, if you are chasing ROI, if you are chasing a lot of comfort, but इतना ही चलेगा कि काम निकल जाए, सरप्लस कुछ नहीं होगा, लग्जरीज नहीं मिलेंगे लाइफ की. When you'll be passing out your MBBS, you'll find yourself you're nowhere. Or आपके colleagues, they'll be partying and going for foreign trips, and some of them will be planning the engagement and going on Saturday evening dates. और आपके लाइफ में आपकी वही नीट की तैयारी चल रही होगी. So but then later down the line you'll feel कि ठीक है यार, ऐसा ही था ये. And surgery also has this surgical branches have this very beautiful knack of filtering out people from your life. ये I don't think किसी और profession में किसी और जगह that the profession itself has this beautiful knack.
So is that a good thing?
Friendship is something that is absolutely non-transactional. Absolutely. The very basic prerequisite of friendship is that it has to be non-transactional. The moment it is transactional, it is not friendship, right? So अगर आप suppose PG second year हो, right? And कोई senior resident है जो आपको, he's helping you with the studies, he's helping you with the notes, he's helping you with the surgeries. तो आप अपने convenience के लिए you may call him your friend or colleague, but he's actually your guru, right?
Very true.
If you're a PG third year guy and you like a certain, first year MS gynec lady, right? And out of that busy schedule, आपने थोड़ा समय निकाला to go on a coffee date with her, or to meet her, or to speak to her, or to text her. So आपने उतने busy schedule में से time निकाला सिर्फ उस particular person के लिए. आपको ये चीज़ लग सकती है कि friendship है, but you're looking at a potential life partner. It is not friendship, but आप बोलते यही हो कि वो आपका दोस्त है. आपने PG पास कर ली, and with one of your colleagues, you share the vision that you'll have a diagnostic center or a nursing home or a hospital, and you both invest money in it, right? So आप कहते हो he's my colleague, but actually he's your potential business partner, right? Now what is the friendship has to be non-transactional. This is all transactional. Now these equations, they all require certain kind of constant touch. They all require a kind of validation. They all require a certain kind of exchange of emotions, exchange of knowledge, exchange of money. So these are all transactional equations. सर्जरी इन सारे इक्वेशंस को फिल्टर आउट कर देगा. बिकॉज जब आपने कभी किसी से दोस्ती की थी लॉन्ग बैक, राइट, व्हेन यू वर अ किड इन क्लास 10, क्लास 12, कोई रीजन नहीं था. देयर वाज नो एब्सोल्युटली नो रीजन टू बी हिज फ्रेंड. एंड टुडे दैट इज द बिगेस्ट रीजन व्हाई यू आर हिज फ्रेंड. तब कोई रीजन नहीं था उसे दोस्ती करने का, आज वो सबसे बड़ा रीजन है कि वो आपका दोस्त है. सो वो दोस्त आपके रह जाएंगे. और ये सारे ट्रांजैक्शनल इक्वेशन धीरे धीरे सर्जरी.
It's a thought. I like this thought. But there's also an emotional cost to becoming a surgeon. I think surgeons, statistically speaking, have one of the highest, relationship stress and a divorce rate. Now, is that part correct? We found this while we were researching for the podcast.
So I'll tell you, relationship stress, and I'm not an expert on this, but relationship stress and divorces are primarily because of incompatibility, unavailability, and lack of communication, right? Now, if these things are already pre-existing in the relationship, surgery will amplify it. The residency and the post-residency thing will amplify it. बिकॉज एक तो तुम बात नहीं कर रहे हो, एक तो तुम लड़के बैठे हो, और उसके बाद तुम अवेलेबल भी नहीं हो रिपेयर करने के लिए. सो ऑब्वियसली दैट क्रैक विल डीपन. बट सर्जरी पर से इटसेल्फ विल नॉट लीड टू दैट क्रैक, राइट? सर्जरी पर से इटसेल्फ विल नॉट लीड टू दैट स्ट्रेस. But obviously, if there's a pre-existing communication gap, if there's a pre-existing incompatibility, and because you're not available and because you're not earning well, so obviously that crack will deepen or that crack will enlarge. So partly you are correct, but not completely.
So is loneliness also common amongst the surgeons, especially?
No, I don't think so. Surgeons are surrounded by so many people all the time. They have.
But emotionally, they are lonely.
No, like I told you, it's all about how you take friendship. जो भी आपके non-transactional equations हैं, वो lifelong रहेंगे आपके. मेरे लास्ट सेट ऑफ फ्रेंड्स 2011 में बने थे. माय इमीडिएट जूनियर्स, राजेश पाठक एंड रवि कुमार, है ना. वन इज अ लीडिंग प्लास्टिक सर्जन इन लखनऊ. तो वो उसके बाद इफ आई लुक एट इट, उसके बाद जो भी इक्वेशन बना, इट इज ऑल ट्रांजैक्शनल. आई वुड नॉट कॉल माई सेल्फ अ लोनली पर्सन, बट येस, you are not very available for socializing and social events, but you have people around you always. You have your anesthetist, you have a gynecologist, you have your junior surgeons, you have the OT staff, you have the TPA team, you have the marketing team. So I think you're always surrounded by people, but and then you have your family. But yes, we are not very frequent at events.
Let's talk about private practice and corporate hospitals. Is running a private practice, especially for a first generation doctor, is it a risky thing?
Any successful surgeon or any doctor associated was once a first generation doctor, and now he's become successful. So, and I think that holds good for any profession. So it's always difficult for the first generation doctors, but I would say that if you're willing to battle the initial grind, then I would obviously say private practice. But if you want little certainty, little comfort, a kind of more certain patients, then it's the corporate hospital.
Which one has a better earning potential, private practice or a corporate hospital?
10 years down the line is private practice.
Hands down.
Absolutely. There are no two ways about it.
And what's the pros of working in a corporate hospital?
You have a team. You have well-defined working hours. You have a certain amount of money that will get credited in account every month. You have everything is being taken care of by a lot of people. So you don't have to chase patients. The marketing team is doing it for you. You don't have to make a lot of efforts to kind of bring the patient to the OT table, because there are so many names. So that way it is very rewarding. But then after a point of time, the increment and everything is limited. As far as the money part is concerned, 10 years down the line, it is always private practice. Always. Any branch.
So first, tell me, what is the ugliest truth about becoming a surgeon that nobody knows about?
Post MBBS, once you enter surgery, so post MBBS, first decade after your MBBS, your everything will be tested. Your patience, your ego, your financial crisis, your peace of mind, your equations.
So you need to be ready.
You need to be ready.
What's your advice to the young medicos, young JR1s, how to balance that out?
So go with the flow. Consider it a part of learning. It's a cost of learning that you pay.
Mm.
God has given you that opportunity to treat and heal patients, and so I think it's a big honor and an opportunity, and I think and that is the cost of learning that you have to pay, and there's no way out without that cost of learning. I mean, you cannot do without it. Eventually, you'll have to give in your everything.
So if a young medico is looking for peace, money, or a work-life balance, they're best to avoid surgery, right?
Initially, yes. For the first 10 years, it's difficult.
You have to say bye-bye to life.
Absolutely.
It's tough. I mean, absolutely. If I just,
So like I told
if I'm
you,
talking to you,
like
it feels so tough.
Like I told you, Nachiket, you don't choose surgery. Surgery chooses you.
हाथ पे खुराक होनी चाहिए.
So you don't choose surgery. I know friends जिनके रिश्ते टूट गए सर्जिकल रेसिडेंसी में, जिनके वर्क लाइफ बैलेंस खराब हो गए, जिनको स्ट्रेस की वजह से गलत सिगरेट की बहुत ज़्यादा आदत लग गई. सो स्ट्रेस तो है और अनसर्टेनिटी भी है. ऐसा नहीं कि ये स्ट्रेस लेकर के इट इज ट्रांसलेटिंग इनटू सर्टेन काइंड ऑफ मनी. ऐसा नहीं है. और आप हमेशा चेज कर रहे हो तो कि अच्छा ये कर लेंगे तो चीज़ें थोड़ी सी ठीक हो जाएंगी. फिर आप वो करते हो, यू स्टैंड कि यार मुझसे 20 साल सीनियर बैठे हैं यहाँ पर भी. मतलब आई एम टॉकिंग अबाउट, आपको लगता है आपने जनरल सर्जरी कर ली. जब आप जनरल सर्जरी कर रहे हो तो आपको लगता है ये कर लिया तो फिर सब सॉर्टेड है. फिर जब वहाँ से निकलते हो, आप सीनियर रेजिडेंसी में घुसते हो तो आपको लगता है यूर नो बड़ी. फिर आप एमसीएच में घुसते हो तो आपको लगता है यूर नो बड़ी. फिर एमसीएच से निकलते हो तो आपको लगता है कि तो पूरी ऊपर हायरार्की बैठी है मेरे ऊपर. तो वो स्ट्रेस है पहले 10 साल का.
लाइफ कभी सेट नहीं होती.
नहीं, पहले 7-8-10 साल, उसके बाद सेट हो जाता है.
So would you make your kid a doctor?
It's a very tough question. I don't know what his calling is. I would want him to become a doctor, but he has to be convinced about it. I would not pressurize him into becoming a doctor. वो बनना होगा तो he would become. I would want him to become a doctor, so that I can prepare him better for things that will come in his life. But there's no pressure as such.
Seriously?
Absolutely.
Honest to God. ठीक है सर, थैंक यू सो मच. अभी रैपिड फायर के कुछ क्वेश्चन मैं तैयार किए थे आपके लिए. तो बहुत सिंपल है. यू हैव 2 सिंपल रूल्स. यू हैव टू बी सुपर स्पॉन्टेनियस एंड सुपर ट्रूथफुल. ऑलराइट, रेडी है सर आप? अ फूड यू नेवर गेट बोर्ड ऑफ.
Handi cooked mutton and plain rice with onion salad.
Okay. One trend in medicine you think should end immediately.
Non-medicals making reels about healthcare.
ये तो बंद हो जाना चाहिए.
Should stop.
Should medicos make reels to basically promote their practice and everything?
As long as it is informative and educational, it's absolutely okay. If it's coming from a credible source, it's okay.
Do you think in today's world, making yourself a brand on social media is one of the highest importance?
Really. Reel देख के कोई सर्जरी करने नहीं आता.
Your most unpopular opinion about work-life balance?
You shouldn't chase work-life balance in first 5-10 years of your career.
One career risk you're glad you took?
Delayed gratification.
Hustle or balance? Pick one.
Initially hustle, later balance.
One decision you're proud of?
Ethics. I've always been ethical.
Thank you so much for being a part of our show. It was a lovely discussion. You gave us a very different perspective about surgery. I think I can say on behalf of all the audience, we are going to love that.
Thank you so much.
And thank you so much everyone for watching today's show. A very different perspective about surgery, the work culture, the hustle, the balance, the income potential about private practice, everything conceived into a single episode. I know you are going to love it. Thank you so much for watching today's show. And as always, do not forget to like, share, and subscribe. Thank you so much and God bless you.